Okay, so this is the fourth one. So I hope you've enjoyed the others. I hope they've made you think and some controversy and so forth. So that's the best way to go with things. Today's speaker is unfortunately not here for family reasons and health reasons and so on, which is interesting because part of his presentation is going to deal with that. And his name is Paul Desjardins. To tell you a little bit about Paul is to say that Paul has had a very interesting, auspicious, and eclectic professional career would be an understatement, a gross understatement. And let me tell you why. He started his undergraduate studies in pharmacy at the University of Rhode Island, graduated in '72, and that same year went to the Tufts School of Dental Medicine, which he graduated in '75. This was followed by a 2-year general dental residency at the Genesee Hospital in Rochester, New York. He then continued to earn a PhD in pharmacology at Georgetown University in Georgetown. So in 1982, he joined the faculty in New Jersey as the University of Medicine and Dentistry of New Jersey, UMDNJ, which is in Newark, New Jersey. I'm sure most of you know that. There he taught clinical pharmacology, therapeutics, and to students, as well as to 2,500 practicing dentists. He also set up a coordinated clinical studies of analgesic agents following extractions of impacted third molar teeth. So that was the model to cause pain and to learn how to deal with pain and to minimize pain as much as possible. These and other studies resulted in Paul publishing over 130 clinical papers. Then his clinical studies also resulted in Paul getting 2 U.S. patents on devices with which to measure postoperative swelling and thereby to try to reduce it with, again, various medications. So he certainly has had a lot of academic experience from that point of view. And later he also became an academic dean at UMDNJ. Paul then left to academics and put his efforts into working in the commercial arena, first in Texas, and then later his career ending in being senior vice president at Wyeth and Pfizer Consumer Healthcare. Although that he is now officially, quote unquote, retired, personally, I don't think he knows what the term means. He still publishes a paper or two a year, and he joins every club that needs his help and works closely with his church to improve whatever needs improving at the church. Sadly, Paul, as most of us have, has had severe medical challenges, either to ourselves or to our family members. And that's really one of the reasons, well, the reason Paul is not here today to give his presentation in person. So today, Paul will share these life lessons that he has learned. And his title of his presentation is Lessons Learned as a Dentist, Pharmacologist, and Throat Cancer Survivor. So this is Paul Desjardins. He's on the screen, I guess. Okay.
Thank you, Mano. Thank you, Mano. So thank you for letting me join you today. I've been very impressed by your technology and your preparation, and I'm disappointed I can't be there today. But as Mano mentioned, we have some family issues, and with a 92-year-old father-in-law, I'm pleased that we're able to keep him healthy and going strong with the support that his family gives him. So just to give you a quick sense, and we have to do this every time we give a continuing medical education or continuing dental education presentation, we disclose what our potential conflicts of interest are. And in the past, I would say over the past 40 years, I've probably worked with the 50 biggest companies that have ever developed pain relieving drugs. The ones listed at the top are those that I've worked with in the past 3 years. I am a co-investigator and a lead pharmacologist on a NIH study right now that we're doing at Rutgers, comparing non-opioids to opioids. And I serve on the couple of boards of Coveris, which is a medical malpractice company. And I was on the board until last year at the South Orange Performing Arts Center. So with that, let me jump in and give you a little sense. There is no company that I've ever worked for who's told me what to say, told me what not to say. So I may give you the opinions I'll express will be my own opinions, but they have been shaped by both my personal experience as a patient and my experiences as a pharmacologist who's been on the side of both dispensing medications, prescribing medications, consuming medications, and working with the marketing and business folks that make our pharmaceutical industry work. And it's interesting that it's only when I started my talk that the people behind me here in Fort Lauderdale decided to start trimming the bushes about 10 feet outside this door. So I'll speak up a little bit, and hopefully they'll be finished with that in a couple of seconds. So let me tell you sort of where I'm coming from and what I hope to accomplish. I'm going to share some personal information with you, my personal story as a cancer patient. I trust that all of you as seniors in your families play an important role in your family's lives, whether it's coaching your kids or grandkids, and a few may be fortunate enough to have great grandkids. I'll talk to you a little bit about how people who are not involved in the primary care of cancer patients can help. I'll talk a little bit about how my dentist and friends helped me on my journey. And we'll talk a little bit about sort of how some of the pain when patients have head and neck cancer, how that can be managed. I think there are broader issues. So my start on this journey began in November 2017. I was in California playing golf, and I noticed one morning as I was shaving that my neck was asymmetrical. What does that mean? It was bigger on one side than the other. And for those of you who are physicians or dentists or somehow involved in doing physical exams, you know that most people are symmetrical. And so I felt the right side of my neck and thought, there's something going on here. You know, maybe it's a salivary gland that's blocked. Maybe it's one of the glands under my neck. And probably nothing. Let's ignore it. So a couple of weeks later, I sort of remembered that I had a bit of an earache maybe a week or two earlier. And sometimes that'll cause swelling of the lymph nodes on that side. Not a surprise, but you know, I've examined in the course of my career probably 45,000 necks for patients on my studies, for my patients when I practice dentistry. And the question becomes, how long should you follow it? And what the back of your mind is telling you throughout this time, it's not a lump. It's something that needs to be there. Paul, you know, you're at that time a 67-year-old guy. Everybody's got a lump or bump at that stage, and let's just ignore it. Well, a month later, I went to see my primary care physician in Morristown, and I saw my general dentist. And both sort of examined the area and said, well, it may be a swollen salivary gland, but let's just look into it a little deeper. I remember calling Mono Millis and saying, hey, Mono, I've got this, what I think is a swollen salivary gland. Who would you recommend that I see to examine this as an ear, nose, and throat specialist? And he referred me to a practice in Morristown. In early January, I had an examination there. And they said, well, let's just not get too excited about this to start with, but let's just do a CAT scan and sort of see what that swelling is. And I noticed in the note that the ear, nose, and throat surgeon wrote at that time that this lump was now classified as a suspicious mass. If a suspicious mass doesn't raise alarm in the minds of a non-physician, non-dentist, it certainly raised suspicion in my mind as that there was something else broader going on. The talked to the ear, nose, and throat surgeon at that time, and he had been trained in Dana-Farber in Boston. And he was really pretty straightforward with me and said, Paul, you're over 60. This swelling has been in there for at least 4 to 6 weeks now. And in my mind, this is a cancer until proven otherwise. Well, that sort of wakes you up pretty well. He said, let's do something not terribly invasive. Let's do a needle biopsy. So they did an ultrasound needle biopsy where they take a long needle, put it into the swelling area. And they identified in the CAT scan, by the way, that these were lymph nodes. They were swollen lymph nodes. So they draw out the fluid from one of the nodes, and it's clear yellow fluid, no cells in it. And the biopsy comes back from the pathologist, no abnormal cells. Well, I'm ready to declare victory and go on with my life. The surgeon says, Paul, I've seen too many of these that are false negatives. I think what we should do is do a pan endoscopy. And this is where they put you to sleep. They take an endoscope and they put it into either through your nose or your throat. And they look around the back of your throat, down the bronchi, and around your vocal cords. And all of a sudden, when I woke up, my life had changed. And he had done 6 biopsies. One of those 6 biopsies was positive for a squamous cell carcinoma. This is the next set of quotes is from the diary that I started keeping around that same time. That once I heard that, I was out of control emotionally for the next 2 or 3 days. Going through my mind was like, do I need to get my affairs in order? Is this a death sentence? I very quickly felt old and anxious and uncertain. And where do I turn for advice? You know, how do you get this treated? What's going on? At that time was a coordinating investigator. We were doing a study in 8 clinical research centers in Mexico. So I asked my second in command to take over as the coordinating investigator to coordinate those weekly meetings with the doctors and dentists. And I just took 3 or 4 days to just let this sit in my brain. And you know, I'm a professor. I like to think rationally that I can make some decisions. But during this time, I was really emotionally overwhelmed. And I needed to have people talk to me a little bit or let me talk about what my concerns were. It was challenging for me to speak with family and friends. And among the questions I went through is, how much should I tell them? Should I tell them all the information that I had? Should I reassure my kids that this is nothing serious, we can treat it? Oh, well, wait a minute, Dad, this is a cancer. What do you mean it's not serious? And so these are some of the thoughts. And the reason I'm bringing this to you is that with most of the folks whose birthdays I heard today, there are very few people in their 40s and 50s in this group. There are probably more than a few members of your own family who have been through or are going through this cycle in their lives right now. And these may be some of the thoughts that they're having behind the scenes that they may or may not be willing to share with you. Interestingly, after I had this diagnosis, I had 4 or 5 neighbors come to me and said, Paul, you need to know that I had prostate cancer 6 months ago. I never talked to anybody about it. I had a few of my wife's friends say, I go to the dentist. They never examined my neck. How the hell did you ever find this swelling in your neck? My comment to them is you need to find a new dentist if they're not examining the inside of your mouth or your neck on an annual basis. So here are some of the lessons that I learned as a dentist. Number one, dentists and physicians must do a routine head and neck and an oral examination. Most of the time, the dentist will do a more detailed head and neck examination than many general practitioners, primary care physicians. You cannot ignore neck swellings, especially if they last longer than a month. That has to be followed up by someone. For most general dentists, they need a referral network, whether that's an oral surgeon or ear, nose, and throat, or a general dentist, a head and neck surgeon, because those people generally, with those, if that neck swelling turns out to be a cancer, you really need an oncology team to treat you. It's not a single doctor anymore. The fourth bullet is a key part of the bullet, a key part of the lessons learned, that even general dentists and even family members, when you're at arm's length from those family members, you can help them get to appointments. If somebody's going to be treated for a head and neck cancer, they will likely have some type of radiation and chemo, and there has to be a follow-up before and after to minimize the complications. And the other piece, to those of you who are not doctors and dentists, is to do your best to stay connected to the patient. And I've told my colleagues who are general dentists, once a month phone call to the patient, say, how are you doing? Is enormously helpful in providing someone the support. And one of the other comments I would say to you is you may be the only family member to hear a new symptom. And I'll give you another example of that in a few minutes as well, on how one of the other, it's actually a nutritionist that I was seeing at that time, helped me in dealing with the pain. And the other aspect of this is that my tumor was related to a latent HPV, human papillomavirus infection, that I have no idea how I acquired that infection. It could have been 40 years ago, 50 years ago. And these viruses activate, and they can cause these head and neck tumors. They can cause throat tumors. That's the biggest area in the head and neck region where there are more and more tumors growing every year. But we expect that within the next 10 to 15 years, those numbers will begin to drop because we've got an effective HPV vaccine, which is Gardasil. And these tumors are preventable, but they don't only cause head and neck tumors. They're one of the leading causes right now in women of cervical cancer. So the Gardasil vaccine is only effective, it's only been proven effective if you're vaccinated before age 26. It doesn't treat these types of cancers. But if I can prevent my grandchildren from ever having one of these and going through this, it's well worth it. And I have a lot of discussions with people who, let me go back for a second. Okay. Several people in my network also said, Paul, what can I do? How can I help you? So Flashback to Morristown, they had done these 6 biopsies, but the ENT surgeon had not warned me about how much pain that would be involved afterwards. And in the first 10 days, I lost 12 pounds. Now that's a pound and a fraction a day. You cannot continue that. When you're going to be treated afterwards, for most people, they will lose between 50 and 30% of their body weight. So getting control of the postoperative pain was one of the important things that my general dentist helped me, and I'll talk to you about how he did that. The other thing is I activated my professional network. One of my colleagues in Austin, Peter Black, was my second in command. And his comment was, one of his women friends in Austin, her husband was the CEO at MD Anderson. Well, Paul, do you want to come down to MD Anderson? No, Peter, I don't want to travel 2,000 miles for my treatment. If I lived in the middle of Wisconsin, or if I lived in the middle of Wyoming, maybe I'd be willing to do that. But, I have Memorial Sloan Kettering that's 20 miles outside my front door. So my general dentist also referred me to a radiation oncologist who was seeing a family member at Memorial Sloan Kettering. And it became very quickly obvious to me that if I wanted a standard of care treatment, that I would go to one of the big university medical centers, and Memorial Sloan Kettering was my top choice. And a lot of this was determined by geography as well as contacts. Interestingly, and this is another byproduct, Peter Black put me in touch with this woman whose husband had been the CEO at MD Anderson. And she said, well, how can I help? I said, well, I don't know who to turn to. And she said, could you speak to the head and neck surgery department at MD Anderson, see who they would recommend at Sloan Kettering? Not only did she find that individual's name, so 36 hours after that conversation with her, and I remember it like it was yesterday, at about 6:30 at night on a Thursday night, the phone rings, and I answer the phone, and he says, Dr. Desjardins, yes, this is Ian Ganley. I'm head of head and neck surgery at Sloan Kettering. How could I help? What? It may well be that one of your colleagues, one of your friends, one of your neighbors has some of these connections to help get to the right person quickly enough. For a number of patients, the most frustrating thing is not knowing where to turn, and all of a sudden they see three doctors before they finally get into the hands of a trusted oncologist. So in the next week after the conversation with Ian Ganley, we assembled all the test results that I had, the scans, the biopsy results. They even wanted the pathology slides, so the little slices of that biopsy that they could look at under the microscope themselves. And one of the things that happens in these sophisticated cancer centers is you have one point of contact. There's a person on the team that says, you need to send all the stuff to me, and they assemble your slides and all the information along with the scans you've had to that point. Very quickly, there were 3 appointments, one with the surgeon, another with the radiation oncologist, and one with the medical oncologist, all within the same 2 or 3 day period of time. They then bring your results, your diagnostic information, as well as your medical history, to a group of physicians and nurses, and in my case, some dentists were on the team as well, called the tumor board. And Dr. Mono Millis, was on tumor boards at UMDNJ for a number of years. But it takes about a month to get through that process. And during that month, I can tell you, I was getting impatient. And again, from my diary, I just feel like I got a ticking time bomb in my neck. And I had another appointment with my primary care physician, who just said, Paul, don't panic. It took a month it generally takes about a month to get the treatment plan done, but you want to make sure you've got the most effective treatment options in front of you. And so this is not a time for panic. 1 month in diagnosis and treatment is not going to make that big a difference. Just hang in there and keep me advised as to what's going on. During that time, I did my best to learn as much as I could about this tumor and its natural history. What are the typical treatments? What are the how long does it take to recover? What's the chances that they can cure this? And interestingly, I had a cousin who was living in Bahrain who had the same tumor about 5 years earlier. And he met with me for about an hour and a half to talk about what his journey was. And my notes from the conversation with him, underlined and highlighted, was, Paul, this is a long, slow walk. Stay calm, keep moving forward. It may seem like every day not an awful lot is getting done, but you've just got to be patient to get through this because they can cure this. The other aspect that I learned, and this may be useful for some of you who have family members who have serious illnesses, or if you have a serious illness, there is a charitable website called Caring Bridge, where you can establish your own website where you can put a note in before every visit, after every visit, if something else has happened. And I found very early on that I had a number of cousins that wanted to have these big emotional conversations where, we were both in tears afterwards. And I said, I just can't do this. I've got 17 cousins. I can't have 17 of those conversations. I have 1 or 2 a day, and I'm wiped out mentally for the rest of the day. So I heard about this site, Caring Bridge, and I started my own site where every time that I had a visit and there was some progress going on, or they were starting treatment or finishing treatment, I would make a note. And sometimes it was a paragraph long, sometimes it was only a couple of lines long. But you can invite people to come to your site so that they're not calling you during this time where you can't speak. And again, I was having head and neck radiation, and my throat was so sore I couldn't talk. And what you see at the bottom of this, a little New Jersey humor, I figured, I've been living in New Jersey for 40 years, so I called it, Paul, how are you doing? Which is pretty much the same thing that most of my friends were asking at that time. Being a Red Sox fan, I had to put a Red Sox picture in there somewhere. And during this roughly 6 months that I went through both treatment and recovery, you can see I had over 1,600 visits to the website for people who were just checking how I was doing. And they would leave me encouraging notes that I could read without having to engage in a long conversation. So this is one of those sites that if you have family members that are going through a serious period, there's no charge for this. You can do this. They exist on donations. Caring Bridge is the name of it, caringbridge.org. So what did I learn as a new cancer patient during this time? And periodically, and I've talked to Mano many times, that when I lecture, many times I like to just sort of go to the balcony and sort of see what's happening. What I learned during this time? Are we doing the right thing? And not be so embedded in it. And as a new cancer patient, it's very easy to tell people to stay connected. And it's very hard for patients to do. It's like their family and friends have to reach out to them. And even if it's just a card or a text or a quick phone call to let them know that you care, it's absolutely critical to stay connected. It's just so easy to become isolated. My comments to new patients is lean on your family and friends. During this period, I felt like I was being carried by my family and friends. They offered to bring me to Memorial Sloan Kettering. I was treated at the site in New Jersey, in Homedale. And sometimes my wife couldn't either. She was tired or she had other commitments. They offered to come down. Several one of them just said, "Oh, come in. I'll sit in with you. Even if your wife wants to drive, I can drive you both. But I'll sit in with you for an hour or two while you're getting your chemo." And, so the message is friends, family, and neighbors want to help. So let them. And the other thing is having conversations with other patients who have been through some, they may not be the exact same tumor, cancer, disease that you have, but they've walked the walk and they've learned something. And sometimes just, you don't know what words you're going to bring to tell people, but you're keeping them connected to what's going on. Maybe just update them on what your latest tennis games are with your friends. So here were the two alternatives that were offered to me at Sloan Kettering. The first was the standard of care, which is, this is the standard treatment without any experimentation. It would be 7 weeks of radiation. There are 2 different types of radiation now. There are actually probably 4 or 5 different types, but they offer this IMRT where it's a very focused radiation beam and the collimators are opening and closing as this thing's going around your neck. But altogether, there would be 70 Gauss, which is how they measure radiation delivered. So 70 Gauss total. There would likely be 3 cycles of chemo, which would be some type of platinum-based drug. And likely there would be a neck dissection at 4 months where they would look for lymph nodes that were still had cancer cells in them. I will tell you that as a hospital dentist who had treated cancer patients, after they said likely neck dissection, I did not hear another word from that appointment. My brain was back on just how sick my patients were, how disfigured they were after they had neck dissections back in the 70s. And thank goodness my family was there to listen and hear the alternatives. So the alternative was a research protocol they had at Sloan Kettering, which had a radically reduced dose of radiation, specifically for HPV-related tumors. They call these oropharyngeal carcinomas. They are different from traditional or the types of cancers we saw in the 50s, 60s, and 70s. Many of those cancers, which occur mostly in the front part of the mouth, on the tongue, under the tongue, and in the cheeks, are related to tobacco and alcohol consumption. Those are not easily treated, and there are fewer than 20% of those patients that live 5 years. For the HPV-related tumors, they have like a 98% cure rate with traditional standard of care. This one was a level of care that promised to have fewer and shorter duration side effects, because the chemo and radiation is really what produces the most significant side effects. And with radiation, it builds up, it's cumulative over time. There would be 2 cycles of chemo instead of 3. But you needed to know with a different type of PET scan whether or not the tumor was hypoxic. In other words, did the tumor have oxygen? Did the tumor cells have oxygen in them or not? If there is oxygen within the tumors, then you can go on to this protocol. If it's not, if the tumor is hypoxic, you have to get the standard of care treatment. So when I first started this, they did a scan and my tumor was hypoxic. That means it did not have oxygen in it, and I would not be eligible for this protocol. But they said, Paul, remember your strategy, stay calm. After two weeks of radiation, we see that many of those tumors now become oxygenated. And I thought to myself, well, just my luck, it's not going to be oxygenated. And went back for another scan 2 weeks after the radiation. The nurse came out, gave me the huge hug, and said, you're oxygenated, you're oxygenated. Well, I knew I was oxygenated, but is my tumor oxygenated? What are the lessons I learned as a patient? So we've talked about lessons that I learned as a dentist. Another one as a pharmacologist was some of the takeaways from the treatment planning visit, where the doctors talk about what your options are. Number one, I could not, and again, after high school, I've been in college, graduate school, dentist school for a total of 12 years. I couldn't absorb all the information. My brain froze, as I told you before, after the words neck dissection, because that was so scary to me. Fortunately, my wife, Kathy, and my adult children were with me, and they could hear all the information and what the pluses and negatives were. Well, why wouldn't everyone go on to the low radiation protocol? Well, number one, if your tumor is hypoxic, you can't. The other alternative is it is research. There's no guarantee that it's going to cure you. They had good preliminary results with these type of tumors. They had already had, I think, 45 patients at Sloan Kettering, and they had done about 5 neck dissections in the first 5 patients, and there were no living cancer cells. And so there was a good idea that this was going to be useful. But again, leaning on family, hopefully you've got someone in your family who has a little bit of medical training that they can help understand the complications. And I went into that visit with a 2-page list of questions. What if we don't treat it? What happens if type of scenario. So here, I call this slide showtime. Treatment started March. Remember, November is when I had first detected the swelling. January is when I had those first doctor's visits with ear, nose, and throat. February, they did the biopsy, and they needed to wait for about a month for that to heal up. So the first phase, Sloan Kettering said, we need to rebiopsy to be sure of exactly what tumor we're treated, make sure, there's no other areas. So in that time, after they rebiopsied, I was in the hospital for 2 days. The second phase, which started about a month later, was that I would have that reduced radiation therapy and chemo. It's not one or the other. On week 1 and 3, you get both of those treatments. On the week in between, you had only radiation. I was fortunate that, again, from Maplewood, New Jersey, the last thing I wanted to do was travel into New York City every day to Sloan Kettering. But Memorial Sloan Kettering Cancer Center has outpatient centers. They have one in Homedale, just outside, and they've got another one, I think, in Basking Ridge, where I did some of the consults as well. My chemotherapy consisted of carboplatin, which was administered as an infusion, sitting there for it was about 2 hours where they infuse it. And then I had a pump that was stuck to my chest, and I had a port inserted in my chest where 5-FU, it's 5-fluorouracil, is another chemotherapy drug. But that pump, which is amazing technology, pumps in this anti-cancer drug at a constant rate over 5 days. And it's not an electrical pump, it's all self-contained. And to me, I'm enough of a geek that the technology for how that gets administered was just amazing to me. The treatments, chemotherapy and radiation, were then completed. So again, it was a total of about 5 weeks total. And the third phase was the recovery phase, where I can tell you after 1 week, I felt like I was going to have no side effects. I got this made. There's no pain in my mouth. And I remember going back on the Monday on day 8, where those sores in my mouth were just starting, where I was walking in, I was in tears. Yeah. Just take a sip for a second. The last phase of the protocol which continues. I'm now about 5.5 years after treatment. And there are still periodic labs, a quality of life questionnaire, a questionnaire about how disabled were you or are you after this head and neck treatment, a PET scan every 2 years, and they still do swallowing studies and MRIs. Whoops, come back soon. Here are, and again, this slide is probably one that my oncology and radiation colleagues and oral surgery colleagues have taken note of. I had the severe mucositis, and if you've never heard of mucositis, it's like a full mouth canker sore. The chemotherapy kills cells that are rapidly developing, which is what cancer cells are. The other cells in your body that are rapidly turning over are the oral mucosa, the inside of your mouth. And so the chemotherapy sort of kills those cells that are turning over on the inside of your mouth and your nose. And during this time, I also developed a very dry mouth, which was especially severe, and it continues. Fortunately, the mucositis resolved after about 4 weeks. But during this 4 to 6 week period, everything pretty much tasted like I was eating cardboard. My sense of taste was gone. I had a lot of daytime xerostomia, and I remember at that time Mono Millis calling and saying, "Paul, with all the patients I have, what still works well is lukewarm water and a teaspoonful of salt. Just rinse your mouth as often as you can." And it was probably one of the best pieces of advice that I had during this period of time. I had interesting, not only difficulty swallowing, but there was such pain during that time. I needed to use a mouthwash to numb my mouth completely for 20 minutes so I could even swallow like those protein drinks. Fatigue, where I remember putting into my Caring Bridge site that if I catch the SOB that put the 20-pound weights on my ankles, I'm going to kick his or her ass. And it's just literally needing to pull myself up a flight of stairs to sleep for 3 or 4 hours every afternoon. Other things, you're getting radiation to the muscles right next to what moves your jaw. And so every time I'd be yawning with all this fatigue, I would get these cramps in these muscles that control my jaw. And during this 5-week period, I lost a total of 34 pounds. I've regained 10 of those 34 pounds. It is not a recommended diet I would recommend to anyone, but I feel much better after getting those other 25 pounds off. My taste perception has come back. I can pretty much taste most foods now. What I will tell you is that for the first year, the nerves in my mouth were so sensitive. They were sensitized because of the radiation and chemo. Any even mild salsa would just bring me to my knees. I just couldn't take it. And that sensitivity and those nerves dissipated over time. But again, it was a secondary effect of the treatment. And another unusual thing that happened to me is I developed a drop foot. That is, when I'd walk, whenever my left foot was being picked up, the foot would drop and I'd hear it dropping on the floor or on the, so I wasn't walking normally. But no matter how precise they try to be with the radiation, there's always some scatter that goes on to the other tissues as well. So what I learned as a pharmacologist, I've been studying pain relievers for the last 40 years. Interestingly, after spending maybe the last 10 years trying to convince dentists not to write prescriptions for opioids, I realized when I was in the hospital, I needed those opioids. My pain was so severe after the biopsies. But even in the hospital, they're hazardous. I had a roommate that had flown in from India to be treated for a spinal tumor that he had, and they were trying to move him from a patch of opioids to injectable opioids. they accidentally overdosed him. And life gets real scary when you're sitting in a room with 30 other people trying to revive your roommate after they overdosed him. Interestingly for me, Tylenol, the oral syrup, was among the most effective pain relievers, and this topical mouthwash, which every dental school teaches dentists about. We like to refer to it as magic mouthwash. It's essentially lidocaine, the same stuff they inject to make you numb, but in liquid form. And I would say that my dental care, rinsing out my mouth with this, probably consumed 2 to 4 hours every day. What I didn't realize is that when you've got like this mucositis going on, your body is trying to produce mucus to cover your mucosa. And you constantly feel like you've got phlegm in your mouth that you can't get rid of. The other pieces that happen is that during this time when you can't eat, they're trying to keep your weight up. And they combine protein shakes and they give you the anti-nausea medication called ondansetron. When you combine that plus opioids, then you get serious constipation. And so that's got to be treated. But to me, the hospital portal, since I could go in and see what the results of all the tests and lab scans and MRIs were, was useful for me to something as simple as, when's my next appointment, when you've got about 8 different doctors you're seeing. Well, none of you are prescribing dentists, so you don't need the prescription for the magic mouthwash, but it's basically a local anesthetic combined with something to hold it against your mouth, and usually they include nystatin so you don't get a fungal infection. So who are those folks that really helped me through this walk? My family, my wife, my kids, my docs and nurses who treated me at Morristown Hospital, and to my 3 doctors at Memorial Sloan Kettering, Dr. Nancy Lee, Ian Ganley, and Lauren Michelle. My general dentist, interestingly, a speech pathologist, Louise Cunningham, who she noted when she examined me that I'd lost another 10 pounds. And she got in touch with the palliative care team and said, listen, we got to manage this patient's pain. And I had not talked to anybody else about this, but when I had to do these speech tests, she was able to pick it up. There were virtually dozens and dozens of nurses and therapists, technicians that welcomed you to Sloan Kettering. And they've always got a smile on their face, even though they're dealing with some patients who are going through this rough time. Other family members who had helped and talked to me, helped me find my footing early on. And to the dozens of friends and family, neighbors who carried me, mono sometimes. They literally carried me. Other times it was carrying me in spirit. And to my colleagues in Texas who connected me with Sloan Kettering. And who were the 5 best reasons for why to fight through all this? And these are the one in the center is now 14, just started high school in Washington, D.C. The others are all in elementary school, and we've got soccer players, lacrosse players, gymnastics. They're a part of the routine. And by that October, I could actually see this play. I went to see Red Sox Game 5 against Texas, and this is if you're a Red Sox fan, this is one of the best standings you've ever seen in your life. 61 games ahead of Baltimore, and no matter what, 8 games ahead of the Yankees. So I apologize in advance to all of you who are Yankee fans, but whoever you cheered for till you were 10 years old, you cheer for them the rest of your life. So Joel, I'm happy to take questions at this time.
Okay, our first question is from DJ Perrone, and so he will appear here on the microphone. We'll also take questions online.
Well, thank you very much, Dr. Desjardins. I must admit, I was expecting a French accent with a name like yours. How did you get the name, exactly. The French name?
Great. So I can hear you. Yeah.
Is he going to answer?
Yes.
Anyway, You can answer later. My question is, you are a scientist and you like to analyze everything and understand everything. Most of us are not scientists. We don't necessarily like to analyze every single little details. How am I going to treat it and how much radiation? Most of us think the treatment of cancer, we have protocols, and I know those protocols change. And one of the big change for the treatment of HPV-related cancer has been to de-emphasize the treatment. How low can we go in the amount of radiation? And you've showed that very clearly that smaller treatment can be quite beneficial and successful, and you're proof of it. The only thing that I would not possibly recommend to the people here in the audience is your process. You have wasted a month going to Memorial Sloan Kettering. At some point, as I said earlier, we have protocols. There are protocols. Most institutions that treat patients have a tumor board. So my question is, in retrospect, wouldn't you have been better off running around the state and the states? You went to New York and have your treatment close by to home. Maybe you trust your team and go with it. That's what I did when I had my prostate cancer. I nailed down the team close by, went through all treatments and fine, and be done. Of course, it was not as drastic as oropharyngeal cancers. So my question is, in retrospect, would you have done something else? And also, I want to know how you got a French name. Thank you.
Well, let me answer your last question first, and that is, I grew up in Rhode Island in a French-Canadian family. So until 6 years old, I didn't speak English. And my parents and grandparents always spoke. I was the eldest grandchild. So parents and grandparents on both sides always spoke French. And I didn't speak English till I went to the first grade. With respect to the treatment delay, another aspect that I did not dwell upon was that the surgeon that I saw in Morristown, at Morristown Hospital, committed 3 or 4 drastic errors that I would never encourage my oral surgery residents to do. Number one, he never came back to talk to me on the day of surgery. So I waited in the recovery room till about 10:30 at night. And he spoke to my wife and my children, but never came back to talk to me. So wait a minute. Talk to the family, but you don't talk to the patient to tell them what's going on? So error number one. He had not adequately prepared me for the amount of pain I was going to have postoperatively. And for literally the next 10 days, I couldn't eat anything. I didn't have appropriate medical care during that time. When I called his office 4 days into this and said, listen, I've got severe pain. I really need something to control this pain so that I can eat. Their office never called me back for 36 hours. The patient calls your office in severe pain, you cannot wait 36 hours to respond. It turns out he and his partner had gone to an oncology conference. The nurse practitioner didn't get the message. Error number 3. Point number 4 is that I wrote him and his medical director at Morristown Hospital and the head of quality assurance to explain to them how I was inappropriately managed, and I never got a response from any of the 3 of them. So that in large part shaped why I'd go to Memorial Sloan Kettering, and I would do it again if I had to. I was pleased that we got an early good diagnosis, but what I asked that group was to let me know how would they prevent this from happening to other patients in the future, and I got no response. They were sent to them by email and by printed mail, and no response from either or 3 of them. So that really shaped my opinion of the follow-up. I've entered in my career 45,000 patients on research protocols, and we have advanced the field because of our research protocols. And I wanted to go to a center where I could find state-of-the-art treatment. The protocols, which were mentioned earlier, that most medical centers follow, are pretty much designed and approved by National Cancer Institute. And those are fine, but they are not the state-of-the-art. They are what the state-of-the-art was maybe 3 years ago. And they'll modify them slowly over time. But still at this point, the reduced radiation protocols are still not the state-of-the-art at this moment. They're not the standard of care, I should say. Frustrating, but c'est la vie.
Thank you. The next question is online from Al Aho.
Thank you for a very human talk. My question is addressed to you as a pharmacologist. My question concerns the advertising of prescription drugs on TV. Some countries like Canada prohibit this. I'm deluged with
You may be frozen.
prescription drugs right now on TV. What are your thoughts on the advisability of advertising prescription drugs on TV?
My personal opinion is that was one of the stupidest decisions our legislators ever made in this country. To have basically marketing folks advertise any number of diseases depending on what the latest drug that they've got available, I think is a stupid way to practice medicine. It drives sales of new medications very high, but many times those are inappropriate decisions. They're getting the most expensive prescriptions. And so my personal opinion is that I was never driven when I was a practicing dentist, doing a lot of root canal treatment, by what patients would come in. And many times they came in with misinformation. And so, the FDA also says, well, you got to give them warnings. Well, how many warnings can you fit in the last 15 seconds by the fastest speaking people in the country? And you need to have a balanced conversation with whoever's treating you for that disorder. So I'm not a fan of online advertising, but I worked for companies that did it. And, that's from when we heard the Viagra prescriptions in the 70s to the latest Ozempic prescriptions now. And many of those are effective drugs. It gets information to patients quicker, but it doesn't tell the whole story. You're welcome.
Okay. The next question is from Rich Jager.
Thank you for your talk. Very informative. My question has to do with your background. You had what I assume was the advantage of so much medical training and experience. Can you tell us how that impacted your approach to getting treatment? And then for the rest of us who don't have that, is there, are there any thoughts about how we can sort of fill in that gap that we don't have that kind of tremendous medical experience?
Thank you. That's a very good question. Absolutely pertinent. You, in most situations, you're dependent upon your primary care physician being able to refer you to the most appropriate specialist. The way, I guess the way I have been shaped and going through the same discussions with my father-in-law is, what are the benefits of, there are three questions that have to be answered with serious diseases. The first question is, what's the natural history of the disease? If I do nothing, is this going to kill me? If I do nothing, is my quality of life going to deteriorate? And then if we're going to do something, what are the benefits and what are the risks? And I'll protect my father-in-law's confidentiality by not giving you his name, but he was discovered to have a small squamous cell tumor on the outside of his ear. He was referred to a dermatologist who did a biopsy, determined what it was, and then he came to see a cancer surgeon here in Florida. The surgeon was ready to do an extensive procedure to explore lymph nodes, to do a flap back over the ear so he had something. But the person who served as his primary care doc is his cardiologist. And the cardiologist said, absolutely no way would I allow them to take you off your anticoagulant medications. And my father-in-law has a number of high-risk situations. He's got congestive heart failure and a few other disorders related to cardiac conditions. And in this case, his primary care doc, who made the best decision, was the cardiologist. And he said to my father-in-law, he said, well, let's just assume we went ahead with the surgical plan and they cure your cancer on your ear. But you wake up and you're paralyzed on one side. You're in a hospital bed in a nursing home for 6 months. Is that a good outcome? Those are the benefit risks. Your primary care doc should have a good sense of what your entire medical history. And even in the students that Manu and I were seeing, if they saw somebody coming in on the same medication that my father-in-law was taking, we wouldn't take out a single tooth without stopping those anticoagulants. And stopping anticoagulants was life-threatening for him. So to answer the question, you rely on your primary care physician. There may be another physician in your family or a dentist or somebody who's in the medical field that help you negotiate. My role here is not to make decisions. I become the medical translator. Here are the key questions that we have about family members' treatment. Here's what they're telling us. Does it make sense? Does it not? And try not to offer my opinion. I'm not the primary care doc treating my father-in-law, but I can make sure he hears what his other docs have said. And so to me, that's sort of a lesson of who you rely on and why we have primary care docs there. They are the gatekeepers, whether it's an internal medicine person, a cardiologist. They're the people who should have the broadest picture to help you understand the benefits and risks of whatever the treatment is being suggested.
Thank you. Next question is from Ron Oak online.
Thank you very much. That was a very interesting and also a very good discussion about something that affects people in our age bracket. Two questions. The first question, you chose to be treated by Mario Sloan Kettering's facilities in New Jersey. In hindsight, was that a wise decision, or would you have preferred to have been treated in their New York facility? The second question is for people in our age bracket. Are there things like age limitations that could affect what kind of treatment we get if we were in the same situation as you were?
The first question is that my three oncologists, so the surgical oncologist, the radiation oncologist, medical oncologist, I saw all of them in New York. That's where their primary practice location is. But once they give the prescription for what the treatment should be, that can be done in any of their other centers. So for me, it was convenience. I didn't want to spend 2 hours traveling each way. But if I was living in New York City, I probably would have elected to go into the city to have all the treatments there. The other nuance was that since I was on a research protocol that was funded by the National Cancer Institute, any diagnostic procedures that were mandated by the protocol, not by my primary care, but if the protocol says you get an MRI every 6 months for the first year, National Cancer Institute paid for that, but it had to be done in New York. So I couldn't do all one or all the other. I think I'm missing the second part of your question.
Whether or not there are age limitations on a patient receiving this same combination of procedures that you did.
Yep. There are protocol requirements. They are called inclusion and exclusion criteria. On every protocol, when you do a research study, whether it is like the ones that Dr. Millis and I did on pain relievers, or like this protocol to treat patients with oropharyngeal cancer, there are strict guidelines of who can get that treatment and not. And sometimes they're age, most of the time they're not. But there are usually conditions about what other drugs could affect the outcomes that you can't be on. What are the other management strategies? What you'd like to know most research protocol is the intervention that we're giving, is that causing the outcome? And so what you try to do is eliminate all those other things that could affect the outcome. And so when I was doing orthopedic surgery with patients who had foot surgery, they had to agree that they'd spend 48 hours with us, and we wouldn't let them walk on that foot for the first 36 hours. We knew that when you had bunion surgery, we would only allow patients older, age 25 up to age 70 participate in those research studies, because some of the seniors above age 70 had so many other medications, it would just complicate the outcomes. And so there are those inclusion and exclusion criteria. I don't honestly recall on the lower radiation protocol whether there was an age criteria. I don't believe there were. But each research study has those selection criteria because you have to report those in the paper. This is going to apply to this group of patients. And, people criticize, well, early on, you didn't have enough women on the study to make conclusions about how women would respond. And so increasingly, we're trying to include a comparable number of men and women on the study. And if you're studying kids that are under age 16, it's like dealing with a completely different population. They're even more restrictive. So hopefully that answers your question.
Okay, before I proceed with the normal way that we end the discussion and so on, I would like to add one more thing to what Paul has talked about. And thank you for a very personal story of a very dangerous situation, obviously. At the same time, Paul was fighting his cancer in our family, and I'm not going to get into a lot of detail. We had a family member of ours who also had a very, very dangerous cancer with a very poor prognosis. And what I'm trying to say to you is what helped, and that person is doing well right now, about 5.5 years later, is that if any of you are faced with a situation like this, then you should know your options with the doctor who's about to treat you. And this is what we did. And the difference in treatment was so huge that we are convinced, my wife and I are convinced that that decision of know your doctor, Google him or her, and find out what experience they have in doing that particular treatment, pretty much like Paul did with his. He didn't like the treatments he was receiving from the first doctor that he went to and so on. He ended up with Sloan Kettering with excellent results, as did we. The first doctor's treatment plan was like this. I Googled him. I looked at his CV and all that. Then we found another doctor treating that. Their CV was like this compared to it. He lived and died that particular cancer. And for that reason, our family member is alive and well today. So always check. If you have any questions, how good is this person? Google it. There's so much information back there. So I just wanted to back up what Paul had, his choices, the way he did it. It worked out well for him. And that's something for you too. Check it out. Look into it yourself. See the treatments. How many of a procedure does someone do and so forth. So again, Paul, thank you very much for a very personal walk through your life and how you were helped by your family and friends and so on. And what our custom is to give you a thank you certificate for giving this presentation. Where can you see? Can you see? Where can you put it?
Yeah, you can do.
Like this. Okay. So Paul, you're going to get this from us. It is the orchid that's on here. And the reason the orchid is here is because orchids, back in the 1930s, when the old guard was formed and so on, at that time, Summit was the orchid capital of the Northeast, maybe the whole country, where orchids were sent throughout the U.S. and outside because of the great the kind of orchids that were available there.
Great.
So we're going to give you that and also the Old Guard salute.
Good. Thank you very much, Mano. I look forward to meeting the group.
Thank you, Paul.
At some point.